Everybody, Doc Parsley here, coming to you from April 8th, COVID day 95 billion. Wanted to just do the daily check-in about putting some rationality to the numbers and to the narrative. So, we've covered quite a few things about, should we be afraid of this or that, and whose headlines are doing what. I'm going to segue a little bit away from exact narrative and just talk about the general concept. The general concept being, which I believe is erroneous, that we've never been here before. This is like nothing we've ever seen, and we should be really scared that this is, going to completely alter. This is going to tear the fabric of society. And I know that seems like hyperbole, but there's a lot of language around that right now. From what I've seen, and I'm trying to keep myself clean of it, but I'm not always successful. So let me do a screen share real quick and let's get into some data. So the first thing I would like to share is this screen here. So this came to me from a text a few days ago from Dr. Anthony Beck, AGB, Anthony Glenn Beck, I believe. If any of you are familiar with him, he is much less concerned about this than even I am. So you can check him out if you want some other information on this. But anyway, the point of all this essentially was we're looking at pneumonia deaths on a weekly basis. We're going to cover why we do it weekly in a second. I'd like to point your attention down here that these pneumonias follow seasons, right? So we've divided the world up, or we've divided the timeline up into something that has nothing to do with the calendar, the solar calendar, or the financial quarters. So what basically this starts kind of when the peak begins, and this is deaths. Will also cover, we're also going to cover things besides deaths. We're going to cover hospitalizations and cases, but again, they follow the same path. And then in sort of early January to early February is when you tend to have a peak that sort of stays up for a while. This goes back to 2013 to current. At some point it kind of creeps out to where we're sort of returned to baseline in most cases, somewhere around week 28, so 6 months into the new year, so June-ish, I guess. And if we look at this 2020, the 1920 started back, 3 months, late September, I guess, to January 1. We were following sort of the normal curve. Started heading towards there early January, and then a sharp drop off in pneumonia deaths. Now, interestingly, people from COVID are actually dying from pneumonia, but it's not being categorized as pneumonia. It's being categorized as COVID. However, there's it'd be a very, very subtle and hard distinction to make to say that COVID and pneumonia are substantially different. It is a lung infection. It's a lower respiratory infection, which means kind of below the throat and tonsils and nasal passage. So it's lower in your lungs. There's a buildup of fluid. There's hypoxemia, meaning you can't get enough oxygen in your blood. You start desaturating. These are all characteristics of pneumonia. I'm sure there's some nuances where you could say it's not quite a pneumonia, but the point being, not that I'm saying anyone's trying to hide it, saying that we have this super sharp drop off to a level that's like, even below the average deaths in the summer from influenza, or I'm sorry, other pneumonias. So why this super sharp drop off? Well, obviously we're infecting a lot of people who might have been infected with a more routine pathogen in the past, and that simply wouldn't have been the same classification because of the concern around COVID. So again, not that anybody's lying or hiding it, but we have to ask why this number, and where would this number be without COVID, or if we classified COVID. I think this is without COVID. If we classified COVID as pneumonia, would we simply see another peak that looks like 14, 15? Would we see a much higher peak? And we can guess on that, right? But because we could add a lot of the COVID deaths up in here and kind of give us a weekly total, and this would be a pretty high peak. But I'd like to point out that 3,000 a week is sort of the baseline. This is when we're not in flu season. 3,000 per week is about how many people are dying from pneumonia. So we've been following this for about 5 or 6 weeks in the U.S. So that would be 3,000 a week. That would be 15 to 18,000 deaths. We're not there yet. Again, not saying this isn't a real thing. It is a real thing. It's obviously a real thing. People are treating it. People are dying from it. It is consuming resources, and it's causing a lot of disruption to society, obviously. So let's look at what we're currently dealing with. Almost 1.5 million corona cases worldwide. Again, this is not how many people actually have it now. This is the number of positive tests, is what this should really say. Because not everybody here technically has the disease. Usually we don't call an infection the disease, right? You can be infected with something and not actually have the disease. But in this case, we're calling a COVID virus detection. So we're detecting it in your blood, and we're saying you now have the disease, which even if you have 0 symptoms, it's hard to say you have the disease, because the disease is marked by a cough and sore throat or irritated throat, dry cough, fever, some lack of smell, lack of taste, and a few other characteristic things that kind of classifies the disease. But I digress far too much. So 1.45, let's call it 1.5 million cases where we have a positive test. Out of that, we are currently aware of about 1 million of these people still being a positive test. So that if we tested them again, we would have about 1 million. So about 2/3 of the total number are actually active. This number here has not changed in the entire time I've been following this, which about a month, I guess. I've been looking at this regularly. This is always 95%. This is always 5%, meaning 95% of the people don't need medical attention. So you have 1,057,000 current cases. Out of that, 1,009,000 of them don't need medical attention or even medical monitoring. These are now serious and critical. This is 5%. That serious and critical goes over here, obviously, to make up the deaths. There's a lot of rumor and scuttlebutt about what actually constitutes a death, and if you die from an accident, or automobile accident, and you're tested to have COVID, is that considered a COVID death or COVID-related death? I think right now it probably is. From what I've read, I can't get to the bottom of it. I don't know who would write the overall policy nationwide. I think it's kind of more of a local thing. Maybe even a hospital has the latitude to figure out what they're classifying. So it's still the best number that we have is deaths. So we have 83,000 deaths worldwide. I rounded it up to 85,000. Compared it to Worldometer's population deaths. So worldwide, we've had 15.8 million deaths since January 1. We've had 85,000 deaths since I think China started tracking like November, so tracking deaths around November, maybe as early as October. But we'll just say it all happened in January. So your total risk of death from coronavirus, if you've died, if someone's died since January 1, their total risk of death from COVID was 0.05%, meaning if someone has died in the last, or I'm sorry, 0.5, not 0.05, it's 0.5. So if somebody has died since January, there's a 99.5% chance that they died of something else, meaning that same thing still applies until that number's changed. If you're currently worried about dying from coronavirus, or you're currently worried about somebody that you know and love and care about dying from coronavirus, or just you're worried about people dying from coronavirus, realize that they have a 99.5% chance of dying of something else, the way things currently are. So we should be concerned about it. We should be doing what we can do, but we need to put it in perspective. Okay, and let's talk about the perspective. So if we go down here, this is the current. We have 16 new deaths. This isn't updated every minute, and it's done off a GMT clock, so it's not really with our midnight. So it gets a little messy, but I submit that the more important thing here, this is worldometers, or worldometers, you can go on there, you can organize it however you want. You can click on total cases, it'll give you the total cases. America's tested over 2 million people. Nobody else is coming anywhere close to that. Germany's tested almost 1 million. Russia's tested almost 1 million. So we've tested way more than anyone else. If you look at our total cases, we have the highest number of total cases. New cases, let's see what we had yesterday. Since today's just getting started, basically we're adding 33,000 cases a day. And here's our total deaths. Again, we said if all pneumonia deaths were counted over the last even 3 months, we would have basically 9,000 deaths, right? That would just be through March. So, we're higher, but how much higher are we? I don't know. This was a huge number. By far the biggest number we've had. I think the highest we've had before is 1,300. It hovered around 1,000, between 1,000 and 1,300. It hovered around for 4 or 5 days. It seems to have gone up now. Hopefully that's anomalous and we aren't going to a 2,000 average, but we could be. Even if we are, though, remember, this hasn't changed with the total numbers going on. This is still the same. It's still 95% mild, 5% critical. Only about 1 in 5, 20% of the serious cases become deaths, meaning it's approximately 1% worldwide. And that's if we know all the cases, which of course we don't. It's 2 to 3 times that, which puts the death rate likely in the neighborhood of the flu. Again, it's not the flu. I'm not dismissing it. I'm not saying it's not novel. I'm not saying it's not dangerous. Let's just keep perspective on it. So here's the number that I think is the most important. So if you look at, let's see, hold on. Let's look at total deaths. Italy currently has the highest, Spain, US. All right. So this is the numbers. Now, interestingly, Italy has 60 million people all up. The US has 330 million. Spain has 46 million all up. 330 million. France has 65 million. The UK has 66 million. So we can't compare their total deaths to our total deaths. So over here, they have deaths per million in the population. So look at deaths per million in the population. Really small populations suffer the most from that. It's kind of the smaller the population. But if you look at this, like US is way down here. I mean, it's like number 16th or something, only 39 deaths per population. Now, of course, not everybody in America is currently at risk of this because it's focused in some cities. So I added up. If you took New York City, if you took New Jersey, Michigan, Louisiana, California, which is an anomaly because it's not all California is at risk, but the way it's being reported is just California. And California has reasonably high rates. that California's 40 million. I think probably we should take that down to say like it's probably only 10 million of the whole population, because it's mainly just LA and San Francisco right now. And then Washington State, 7.5 million. Again, it's mainly Seattle. But that number turns out to be 80. If you take, if you say only half of California is at serious risk right now, you would drop that down 20 million, would have 60 million, which would be about the population of Italy, which would then put our expected new deaths, Italy, who's actually recovering from this, they're down to 600. They were around 1,000. So we have a much larger population, so we're going to have larger numbers. But the interesting thing is that this 1,400 in France, that's the biggest number outside of the US I've seen put up. It's always hovered around 1,000. And it's somewhere around 1,000 per 50 million kind of at risk. Of course, the entire country of France is not at equal risk. But if we just arbitrarily do this by country, which we should probably do geographic density or something like that. But if we do that, my point being that the U.S. total death per population is still pretty low. Here's the most important number, I think, is the serious and critical cases, because we've already said that all of the deaths are going to come from serious and critical cases, right? Those are over here. The mild conditions aren't going to die. So how many serious and critical cases do we have? Well, we have 9,100, right? Currently, we still have the same number. And if we go back to 2 days ago, we had 8,900. So we've only gone up a couple of hundred cases, even though we've gone from 367,000 total positives. We went up to today 400,000, and we've only added about 200 serious or critical. Maybe this isn't updated, so let's say it's 400 serious or critical. Well, now we're only looking at 5%. That's the serious and critical. That's the 5%, right? If we're only adding 400 to that, and it's going to be essentially 20% of those, so 1 out of 5. Let's say we're adding 500 to make it easy. We're going to expect an extra 100 deaths. So again, this death rate isn't skyrocketing despite headlines. The serious and critical is the best predictor of what this new deaths number is going to be. Not this. This total cases isn't very predictive at all, because if you tested everybody in America, this number would be 50 times higher. If you only tested people who you thought might need to go into the ICU, this number would be a quarter of that. Interestingly, if you look at 2,400,000 positive, that's about 20% of the tests end up being positive. That's actually a pretty low number when you compare to the flu. So again, just making the case, we have been in similar places before, and one of the most similar that I think, and it's being dismissed because it's totally different with a total different rate. I'm going to make the case as to why it's not totally different. And here's why it's not totally different. Because the global pandemic of H1N1, which was the swine flu, which happened 2009, the 2008-2009 season and the 2009-2010 season. So we call that the 2009 pandemic. 284,000 worldwide. I will remind you, currently worldwide, we have 83,000, 85,000, call it. Again, not that that's insignificant, but compared to 284,000, we have a long way to go before this is, every bit as bad. And I'm going to make the case for why we can probably predict this on precedence. The models that people are giving you, the mathematical models, they model the trend that we're seeing. So models essentially, a podcast I listen to, the guy who says models model yesterday and they predict tomorrow from yesterday. So the closer you get to the end point, the more it looks like, the more tomorrow will look like yesterday. So the models get progressively more accurate over time. But if you'll remember, we went from 2 million people were going to die down to between 100,000 and 200,000. We still don't know the time frame they're talking about. I don't know if that's August or a year. Like, they're predicting seasonality, and that's at the end of the season. We don't really know. But now that number is being adjusted down to probably it's not between 100,000 and 200,000. Maybe it's as low as 80,000. I think we're probably going to see it go down to around 50,000. Again, 50,000 people, nothing to sneeze at. 50,000 Americans dying. I'm not saying it's insignificant. I'm just saying let's put it in perspective with everything else. And people say, well, what about the fact that all these healthy people have it? Well, that's true, or these healthy people are dying from it. And that has happened a lot, according to the news. However, again, we go back to the swine flu, and this is from PubMed. And this was published in 2011 because the way we can analyze this data is years later. We can look back and we'll know a lot more about right now than we know right now. But what we know right now compared to what we're seeing, compared to what we've seen with swine flu, what we know about swine flu in the past and what we know about right now, is that over 25% of deaths were previously healthy people from swine flu. Over 25%. We don't have over 25% dying from coronavirus right now. In fact, let's look at how else we can compare this. So let's go over here. And how did I move that? Did that change? I wanted it to go here. Let's share that one. I don't know if we're on there, so I want to change it to this one so you can see my whole screen. I know. Hopefully you can see this. So again, let's talk about what we're currently seeing. So this is from the CDC. It's something called FluView. You can select up to 6 seasons. I'm selecting specific seasons for a reason. So these are influenza hospitalizations. Again, those are serious critical cases. And this is rates per 100,000. So out of every 100,000 people in America, how many people are going into the hospital for flus? And it's important to pay attention to the y-axis here. What is the total number? So we are looking at 67.9% or 67.9 people per 100,000. Going in this flu season right now, this is ending like, I think end of March. So it's a week out of date. Compare that to 2018. We had at the same time period, we had 57. So we have slightly more. Compare that to a bad swine flu, or bad regular flu season, we had 2017-18, that was 97. So 30% more hospitalizations. And then I'm going to tell you in a second why I picked this. This was the second half of the swine flu. We only had 29, or fewer than half as we currently have right now. And slightly more than half than we had last flu season, and only about a third as many as we had 2 flu seasons ago, which was a pretty bad flu season, killed close to 60 million. So why am I showing you this, and why am I showing you 2009-10? Well, here's what we're currently, what I want to point out right now is that flus have seasonality. I'm going to show you this a little more than I showed you a minute ago. And these are the months that have currently been the peak. If we look, April and May have never ended up being the peak, even though H1N1, as we'll see, swine flu 2008-9 actually did peak out here. It's the number of times that it peaked. It was so low that it's not registering in there. So basically my point is, the flu season almost always peaks in February, between December and March, but in February, then December, then March is kind of March, January, I guess are kind of equal. So compare that to what we know right now. This is the 17-18 I showed you was a really bad one. This is hospitalizations per 100,000. Again, we've seen these numbers. Here's this year, okay, and here are average years. So this more than likely also has a lot of COVID in it. So if we look at, again, this is CDC. This is another page of FluView, I believe. Yeah, this is CDC. Look over here. The percentage of deaths associated with pneumonia and influenza is above the epidemic threshold. So flu and pneumonias, this is including COVID. The increase is due to the increase in pneumonia deaths rather than influenza deaths, and may be associated with COVID-19. Well, I think at this point we can say unquestionably it has. It talks about children being affected especially bad this year. This obviously isn't the case with COVID, which is a good thing. So let's look at what the season currently looks like. Here are percentage of visits for what we call influenza-like illness. Influenza-like illness is things that look like the flu, whether they end up being tested positive for the flu or not. And this is the percentage of visits. So how, out of all the healthcare visits during the year, what percentage of them are going in for flu-like illness? Well, our peak was right before January. We had 7%. Out here, let's see, late January, early February, we were 6.5%. And then it dipped down, and now it went back up, and it's kind of back down to this 5.3%. And here are the positive tests. So number of positive tests when they test people who going in for these visits. These are, again, per week. And so we have, 3,500, 4,000 on the y-axis here. Peaking this year, so far, we peaked at week 1, 2, 3, 4, 5. So first week of February, then it started to decrease, which looks a lot like that chart I showed at the beginning. This one over here. Huge decrease. Why is that decreasing? Man, is this going to completely go away? Not so fast. There's a possibility this has seasonality. There's a possibility that it might not have seasonality. This is why I say I think we've been here before. The interesting thing to point out, though, this is an aside, but if we're looking at influenza-like illness and what is actually infecting people and what's killing people, before the 2008-9 season, swine flu H1N1 wasn't anything really on the radar. It wasn't something we were monitoring. If you look now, this pie chart down here, this orange is H1N1 for 2020. So regardless of deaths, so flu deaths annually are between 30,000 and 50,000. Regardless of how many people die, or let me say, is regardless of the infection, it tends to be about the same number of people dying. 30,000 to 50,000. That's a huge range, but that's consistent. That's how many people are dying in America from influenza-like illness. And now, since 2009, that's predominantly made up by a virus that wasn't affecting us before, the swine flu. But it hasn't changed the overall numbers. And there's a good chance that this won't change overall numbers either after some initial pain. And let's talk about that. So 2008-9, I keep talking about that. Well, here is the normal flu season for 2008-9. And here is week 10, and it starts to decrease and goes almost to zero, much like our graph over here did. So we then had this second spike of influenza-like illness that killed people as well, but put a lot of people in the hospital. And look at all of this orange and all of this yellow. That this yellow could be orange. They just didn't test it after. Went from influenza. They said, do you have influenza? Yes. Is it A or B? These people stopped at A. A could be subtyped down into H1, H3, H1N1. So it can be other things, but it's an A or B. So this yellow and orange is all A. Even some of this is A's. The point being that most of the people who had positive tests this year, by a large percentage, were H1N1, and almost all of them were influenza A. Now, here again are percentage of visits. And this is the baseline. This blue is the baseline, the same as when I was talking about it back here. This blue is the baseline. It was 2.5. Now we're back here, basically 2.5. Here's the baseline. We can see a big spike in visits here. That corresponds with this influenza. Goes down, that corresponds with this. Goes back up, that corresponds with this. And then the actual number or percentage of visits for influenza-like illness go down, even though there's a large number of them, meaning that people people are going to the doctor for other things during this period. So this is making up a smaller percentage of the points. I don't know the total number. That would give us some more information, but we'll stop there. All right, so I showed you we had this biphasic peak. So we had two peaks in the 2008-2009 season. Okay, now here comes the uncomfortable part. This is it's very possible this is what COVID is going to do. COVID is going to give us a second peak. That second peak will basically mean that our flu season goes from the normal flu season, almost goes away, and then we have an entirely new flu season, which might actually be bigger than the past flu season. It might not be. Let's see. And then if we switch, if we switch over from 2008-9, we go to 2009-10, this is where it could possibly be good news. So again, these aren't the same ones we saw on the last chart. These are the weeks following, going up to January 1. We still have a big load of H1N1. Okay, so it is influenza A, and we're having, let's see, 12,000 specimens per week at the peak. And what were we back here? We're at 4,000 for influenza. When we go back to this, we peaked at around 6,500. So although this was a shorter period, 2009-8, this is fewer weeks, it had a higher peak. So there's a lot of area under the curve. This led to a lot of deaths. It led to a lot of hospitalizations. The interesting thing is that the normal flu season following, which usually picks up around between weeks 48 and 50 and goes out until the end of March, 12, 13 weeks, something like that, maybe as late as June, that flu season did not exist, essentially. And why did that not exist? Well, because all of the people had gotten the flu essentially before that. So the argument to that would be, well, we don't have, this isn't the flu, this is something totally different. Granted. But when we talk about herd immunity, which everybody wants to talk about herd immunity, what does herd immunity mean? And well, it means that we have a certain population at risk. I'm going to stop sharing here. We have a certain population at risk, and that population is at risk for not only contracting the disease, but also from dying from the disease. And at some point, everyone in the herd has been exposed to the threat. In this case, we're talking about a virus. We could be talking about a predator. We could be talking about anything. But a certain number of people have been exposed to it. After that exposure, a certain number of people are now inoculated to it. They don't have to worry about it anymore. They're not going to get it, and they're not going to be able to spread it. But there was a certain population that was fragile to that specific threat. And that could be the very young, it could be the very old, it could be like the 1918 Spanish flu, which was like 20 to 40-year-olds. So this just happens to be selective for older populations. That gives me one more slide to talk about before this is over. So it's very possible that the total number of people who are susceptible to this, to having a serious or critical condition, and the total number of people who are susceptible or likely to die from this, all other things being equal, of course, there are aberrants, but the total number of people who are likely to be infected with COVID, the total number of people who are likely to have bad outcomes, either serious, critical, or death, that number of people is finite. And as those people perish, there are fewer people to be infected. That sounds very grim. I don't mean this to be saying we're getting rid of the weak or anything like that. I'm just saying that if we look at the graphs in the past, when we have a really long flu season, when we have a double flu season, or even kind of a triple flu season like we had in between 2008 and 2010, we lost the traditional flu season almost completely. So I'm going to screen share one more time. I'm going to talk about this right here, and go to this one. Again, this is what we started with. If we look at the 2019-20, this is current. This are rates of hospitalization. This is 18-19. So last year looks very similar. This is a specifically bad one, looks higher. And this was the end of 2009-2010. This is the end of the swine flu. It was much lower, okay? Now, the other thing is that we take away the overall and we add in the age groups. 2019, 2020, well, let's put the overall back in. It changes. No, it doesn't change them. This is hard to see now, but if you look at the age groups, we can only go out this far for 2019-20. If you look at the age groups, the numbers are, can I get in there? No. The numbers are right there, 93 per 100,000, goes down, and it goes up again at the end. Whereas if you're over 85, it's 290 out of 100. So out of 100,000 people over 85, you would have a 290 chance per 100,000. Out of 100,000 people between 0 and 4, you would have a 93 and 100,000 chance of being hospitalized for this. So this is sort of an absolute risk. Of course, it looks worse as you get older. That's because being older is an independent variable for risk of death from all causes. So if you get in a car wreck at 80 years old or 85 years old, more likely to die. If you fall, more likely to die. If you get any type of illness, any type of infectious disease, you're more likely to die at 80 than you would be at 20 or 40, say. But the rates over here, 2018-19, last season, had the same pattern. And if we look at 2017-18, the really bad season, this had, a really, really high proclivity for older people. If you look there, we were at 1,117 per 100,000 of people of 85. So that's way more virulent. That's way more than going to the hospital for now. And then the last thing I'll say is when we're talking about these, we're talking about these healthy people that are dying, otherwise healthy people that are dying. Now there's a lot of speculation as to how many of those are accurate. Are they just calling anybody with that a death? I'm not going to get into that. I'm not going to weigh into that. What I will say is something that's being overlooked is that this COVID virus puts you in extremis. It causes you to have essentially multi-system organ failure. It's essentially attacking your red blood cells' ability to carry oxygen, which affects all of your organs. And at the end of the day, everybody dies from cardiovascular disease, right? Because you're not dead until your heart stops beating. You can be brain dead, obviously, but you aren't physically dead until actually you have a certain body temperature and no heart rate. So this is just speculation, but what's not being appreciated with this is that if you look at the absolute death from cardiovascular disease, and you break the world up into 10-year increments, so 0 to 10, 10 to 20, 20 to 30, 30 to 40, all the way up to 110, or whatever people live to, the absolute number of people dying in each decade is the same. So there are just as many 30-year-olds dying as 60-year-olds dying from heart attacks. There's a much higher number of 30-year-olds than are 60 years old. So your risk, your relative risk is higher at 60, but your absolute risk is the same. So it is quite possible that these people dying from this, maybe had, maybe we're at risk for this cardiovascular disease. I'm completely speculating. There's no truth to this. This is just an opinion that could explain it. We talked before about viral load, like how much of this virus are you getting if you're constantly assaulting your immune system with it before your immune system has a chance to beat it, and you're a healthcare worker and you aren't protected and you're taking in and taking in and taking it in, well, you have a higher viral load. Your immune system has to do even more to get past it. You're losing more oxygen to your cells. If you're sleep deprived, that's making your immunity weaker. It's making you physiologically weaker. If you're not eating well, that's making you weaker. If you're stressed out of your mind, that's making you weaker. So all of this is true. Our healthcare workers are at a super high risk. And I'm just saying that perhaps the people who are dying don't necessarily have an underlying healthcare issue, health issue that we know of, but they could be in that population, that 30 to 40-year-olds that had a high chance of dying during that year without any awareness that they had any cardiovascular disease. And once they stressed their system, that led to that. Complete speculation, Kirk off the wall, take it or leave it. Hopefully this was helpful. This was a lot longer than I wanted it to be, but such is life. Hope you're all taking care of yourself. I'll be doing a video later today where we actually talk about proactive things you can do instead of just working on the narrative. And I'll be releasing videos of interviews all week with experts that will help you be proactive and taking care of yourself during this uncertain time. All of this is free and none of it's meant to sell anything. I'm just trying to spread information that I hope will be helpful. So until then, take care, and I'll see you when I see you.